Well, we have Mr. Hank with a 60-year-old gentleman with a 30 back per year smoking history, and he presented to us with hoarseness of voice and difficulty swallowing. We did for him a laryngoscope, and it showed a mass, and we did a biopsy which confirmed squamous cell carcinoma. The patient also completed a staging with MRI of the head and PET-CT, and we are here to review.
Okay, fine. So the MRI head revealed a mass located in the glottic larynx and invades the outer cortex of the thyroid cartilage. There are no local lymph nodes appreciated, and apart from this laryngeal mass, the PET-CT scan ruled out any other nodal or distal metastases. Tumor invades through the thyroid cartilage and or invades tissues beyond the larynx, for example, trachea, soft tissue of the neck, including deep extrinsic muscles of the tongue, thyroid or esophagus, are considered a T4A stage. T4B stage is defined as tumor invades prevertebral space, encases carotid artery or mediastinal structures. In T4A, total laryngectomy and neck dissection followed by adjuvant radiation or chemoradiotherapy is indicated in this case. Primary combined concurrent chemoradiotherapy is the standard treatment in non-resectable patients and is also indicated in resectable patients when the anticipated functional outcome and or the prognosis is so poor that mutilating surgery is not indicated.
Mr. Khalid, welcome to the oncology clinic. I actually have received now the result of your lung biopsy, and I would like to share it with you. But before we start, can you tell me how is your cough now?
Well, thanks, doctor. I'm still having this this dried cough, but it's not getting any worse. What are the results? Because I'm very anxious.
Well, actually, the result that came to me now from the pathology department have confirmed that you have a lung cancer. This is what we call squamous cell carcinoma.
Oh dear. That sounds very similar to the tumor that I had in my throat about 8 years ago and was treated with radiotherapy. Could be the same. I think more important, doctor, what could you do about it now?
Well, the tumor that you have reviewed in the PET-CT, and actually it's a single tumor about 2 centimeters in size, which could give us a lot of options of treatment. And you are young, you don't have any other diseases, and you have been only smoking for about 40 years. So I think we have a lot of options that we can offer.
It is very important not to assume that any new lesion represents a metachronous metastasis from prior malignancy. While this lung finding could be a recurrence from head and neck cancer, the patient has been in remission for many years, so it would be uncommon for it to recur now. This new cancer is more likely to be a new primary non-small cell lung cancer and should be treated accordingly. The gold standard treatment for potentially resectable lung cancer is surgery. For those who are not willing to accept the risks or at very high risk, curative radiotherapy should be considered.
Right, so I saw Mr. Hassan in my clinic a couple of weeks ago. He's a 50-year-old gentleman with a strong past history of smoking, underwent concurrent chemoradiotherapy for stage 3 right tonsil squamous cell carcinoma 3 years ago. He presented to his GP with shortness of breath, and a chest X-ray showed bilateral lung lesions, and a CT scan confirmed the lung findings with some bony lesions as well, and the picture is suggestive of metastatic cancer. We biopsied one of the lung lesions, and we hope the histology is available now.
Well, actually, we have the pathology now, and it confirmed the presence of squamous cell carcinoma.
Thank you, Dr. Amr. So as it stands, the exact source of the primary remains unclear. This could be either relapsing from his previous head and neck,
or a new primary, namely in the lung. I just wonder if there are any markers that could differentiate between those two sources, please. Oncogenic human papilloma virus, HPV, especially type 16, has been established as a causative agent in a subset of head and neck squamous cell carcinoma. 16 HPV is detected in up to 82% of oropharyngeal carcinomas, but is not commonly detected in non-oropharyngeal head and neck sites. HPV does not seem to play a role in the development of primary lung cancers. Hence, for patients with oropharyngeal squamous cell carcinoma who develop lung squamous cell cancers, HPV analysis may be helpful in determining tumor origin. For this patient who has got significant smoking history, these lung lesions could very well represent a lung primary. The squamous cell histology and the 4-year progression-free survival from the initial diagnosis of head and neck tend to support this argument. Indeed, if this patient is determined to have stage 4 squamous cell carcinoma of the lung, the treatment plan would need to be tailored to that tumor site.
Mrs. Nadia, which is a 62-year-old and presented with a 5 centimeter mass in the soft palate. We did for her a biopsy which confirmed the presence of squamous cell carcinoma, and immunohistochemistry for HPV showed B16 to be positive. We did also a PET-CT, and we're here today to review the images.
So the PET-CT scan is showing an FDG-avid lesion in the right soft palate consistent with the primary. In addition, there's also an FDG-avid ipsilateral cervical lymph node, 7 centimeters in size, consistent with the lymph node metastases.
Okay. What should we do now?
Team? Patients with HPV positive oropharyngeal cancer have a better prognosis and may not need as aggressive treatment as patients who have HPV negative head and neck cancers. The 8th version of the AJCC staging system has been modified to account for the difference between HPV-related oropharyngeal tumors and other head and neck squamous cell carcinomas. The new system has only 3 stages for non-metastatic HPV-related oropharyngeal cancer. This patient has a T3N3 disease, but as he has HPV positive cancer, this is considered to be stage 3 disease. Treatment options for this patient include concurrent chemoradiotherapy, resection of the primary and lymph node metastases, induction chemotherapy followed by radiotherapy, or systemic therapy plus minus radiotherapy.
This is Acting for Clinical Education. Like, share, subscribe.
Don't forget to check the resources down below and join us every Thursday 8 p.m. for more videos.